Thanks for inviting me to speak on AI in acute stroke. These are my disclosures. So what is artificial intelligence? It's any technique that enables computers to mimic human intelligence. It could be using decision rules, machine learning, and deep learning. What we know about mostly in acute stroke is machine learning. These are statistical techniques that help us in prediction. And then deep learning is a subset of machine learning that permits software to identify and perform tasks like speech or image recognition by exposing neural networks, multi-layered neural networks to vast amounts of data. Here are some definitions. I wouldn't go through them in detail. I just want to let you know about what is supervised learning versus unsupervised learning. Supervised learning is when we train our algorithms using data that is annotated. Computer vision is what we do to manipulate and analyze images. So before we go to our topic, we've got to understand how humans think. When we humans think, and as physicians, when we make decisions, it's not just, our decisions are not fully rational. They're individual motivations. There's the pressure that's around us, societal, community pressure, patient and family pressure. They are what we call heuristics in our mind. There are limits on our attention and how and when we make these decisions. And there are all these cognitive biases that actually affect our clinical decision making. I'll just give you an example. Here's a question in front of you. What is the probability of success in treating a patient who presents to you with a snake bite? Now, how do we answer this question? We answer this question in multiple ways. If I give you these options, I presume some of you may answer 5%, some may answer 95%, but that may depend on what you think is the prevalence of poisonous snake bites. It might be conditional on where you are, some heuristics that you have in your mind, as well as this idea about pre and post-test probabilities in a Bayesian framework. Clinical decision-making is therefore complex. It involves us considering various factors: the patient's age, comorbidities, wishes, hospital resources, what happens when you make a decision, what are the rewards, what are payoffs. Clinical decision-making in the context of acute stroke is also special because time is brain. Acute stroke is an emergency. And so with acute stroke decision-making, we got to balance rigor in evaluation with speed in decision-making. This is critical while we deal with all the things that make us human. We do parallel processing, which means that we are actually making decisions while we are collecting information. And this increases the complexity of clinical decision-making in the acute stroke world. And then there are all these problems with imaging. We have to understand the speed of acquisition. Some of our imaging information needs to be available 24/7. We need accuracy, we need reliability, and then we got to understand costs. So then the question becomes, with all these complexities that are laid out in our effort to actually make the best decision for our patients, how does AI help? AI helps by increasing the accuracy of image interpretation, by increasing the speed of image interpretation, by enhancing the ability of some of these modalities to actually provide us with information that can help us make better predictions, by limiting some of the cognitive biases that can affect our clinical decision-making. And so I'll give you some examples of how AI helps with acute stroke decision-making. AI now, or machine learning algorithms, can now help you with imaging triage and early notification. A classic example is when a scan gets done, and then let's say you are on call, the scan gets processed, and you are immediately notified of a suspected large vessel occlusion. This is a notification system. It doesn't mean that every case is a large vessel occlusion. You got to then look at the scans, but it notifies you early of a suspected LVO. AI and machine learning currently help with image optimization. So the imaging protocols that you have in place, you could reduce scan acquisition times by optimizing image acquisition protocols. You can improve the image quality itself. You can denoise those scans. Artifacts can be reduced. Image resolution can be improved. I'll just give you some examples. Look at these non-con CT scans. They're all the same non-con CT scans from the same patient, and this is the CT perfusion. We can actually change the processing of these scans, change the thickness, change the presentation to actually make you interpret these scans better. Here's an example of what is capable with AI. This is a normal non-con CT scan of a patient who presents with acute ischemic stroke. And here are processed images. And here are processed images with machine learning algorithms applied. These look like CT perfusion images, but they tend to pick up a lesion. And they help you improve your ability to pick up these lesions. But AI also helps with image analysis. And so the key with image analysis is our human visual perception. How much can we actually interpret these images, and how can AI help? Now, if you look at this image here with this bar here, and if I ask you to tell me which side is darker, I guess you'll point out towards this side. But the truth is, based on an intensity scale, this is the same intensity. And so human visual perception can be affected by biases. This is where machine learning comes in. The non-con CT is a classic example. The signal to noise ratio is less, and the non-con CT, because it is used to pick up early ischemic changes, can be improved by machine learning. And so here are techniques that allow us to pick up lesions on the non-con CT automatically using machine learning. See how well they resemble the DWI. We can actually pick up not just acute looking changes, but subacute and chronic looking changes, and discriminate them thoroughly, better than the human eye can do on the non-con CT. We can then present these results as automated aspects, or automated lesion detection on the non-con CT that might very well resemble the DWI MR. AI and machine learning can also help you detect and characterize clots, intracranial clots, that are the reason why we treat acute ischemic strokes. So look at these images, three images that tell you about clot characteristics. Permeable clots are shown in B and C in comparison to impermeable clots. We have subjective techniques like measuring attenuation and permeability using contrast increase from non-con CT to CTA, but we now have machine learning and AI-based techniques that can infinitely better than humans be able to characterize these thrombus on the CT and the CT angiograms. You all know about multi-phase CTAs. It is an extension of single-phase CTA and allows you to measure collaterals very well. This is the first phase of a patient, second phase and third phase of a multi-phase CTA. And if I look at these regions, I can say that the M4 region, M5 region, and M6 region, M4 has no delay, M5 has one phase delay, M6 is reduced extent, which is what shows up on a CT perfusion map too. But we are now able to convert these low resolution, low temporal resolution multi-phase CTAs into perfusion looking maps using machine learning and AI. So AI algorithms are able to predict what the CT perfusion will look like just by using multi-phase CTA. So these are MCTA perfusion maps, and these are CTP perfusion maps. Look how similar they look, and look at the predictions too. Another example here, posterior circulation, the MCTA map, very similar to the CTP map, is able to pick up the perfusion lesion. And interestingly, the CTP, which is very motion prone, picks up the wrong lesion, but with the MCTA, which is less motion prone, using AI and machine learning, picks up the right lesion here. And then what can we do? We can combine all of these together. So we can detect a suspected LVO. We can show you the lesion on the non-con CT. We can use the multi-phase CTA to pick up perfusion looking lesions on the patient and present all this information to you in one place. This is what modern technology using AI and machine learning is capable of doing. Even on CT perfusion, as you know, AI and machine learning algorithms can now help you better segment what is a estimated or a predicted core and what is a predicted penumbra. You have seen these maps before that tell you what core and penumbra are and what mismatch ratios are. Machine learning algorithms can move that prediction boundary further by predicting how the infarct will grow over time spatially. So you can see this. These are prediction maps of how the infarct would be if you open up the artery within 1.5 hours, within 3 hours, and within 6 hours. And in this case, we opened up the artery within 3 hours, and then the prediction, which is this, matches the outcome, which is this. Machine learning algorithms now help you detect ICH, so they can notify you of intracerebral hemorrhage. They can also tell you about whether these hemorrhages will grow over time or not. And then machine learning algorithms will optimize this workflow and optimize communication, collect that information, and then help you provide the best acute care possible for your patients. AI and machine learning algorithms also help you with predictions of outcomes. You can use imaging and you can use clinical information to actually predict the probability of, say, good outcomes. We do these using, our calculators and our prediction scores, but the machine learning algorithms clearly help you do this better. But this has to be put in the context of clinical decision-making. Remember that acute ischemic stroke decision-making happens in the context of time. Time is brain, the treatments are robust, and acute stroke imaging needs to be available 24/7 and has to be reasonably accurate. As I mentioned earlier, this is in the context again of who we are as physicians and all the cognitive biases and the heuristics that we deal with. Let's take a classic example of decision-making. This is not clinical decision-making, but let's take an example of decision-making where, I ask myself, is it going to rain outside and should I take an umbrella? And so I need to make a decision about whether to take an umbrella or to leave an umbrella. And then I know the probability or the prediction that it might rain or not rain. So this is, say, 25%. And so if I go through this clinical decision rule, then these are the outcomes possible. So I could be dry with the umbrella. I could be dry with the umbrella here. And then here, when I don't take the umbrella, then if it rains, I'll be wet. And if it does not rain, then I am dry without the umbrella. But what I can now do as a human is assign payoffs for each of these outcomes. This part is not what a machine learning algorithm is capable of doing. This is the payoff assignment, which is how judgment happens. The machine learning algorithms are very good at these predictions. And so this is what this figure shows. AI algorithms currently are really good at predictions. These predictions, informed by human judgment, result in actions. These actions have payoffs. These payoffs can then be used subsequently, including the outcomes can then be used to improve predictions. But the assignment of judgment is human. And so this is what happens with modern acute stroke treatment, and I presume will happen with modern acute stroke treatment. There's the acute stroke workflow. There are these abilities of these machine learning algorithms to produce fast predictions, image processing, optimizing workflow, and then there's human judgment. And this is how the modern acute stroke paradigm will evolve. There are some pitfalls, though, in the use of AI in acute stroke. We got to understand where these algorithms come from. What are the data limitations? Do these algorithms, when they train themselves, do they have the necessary counterfactuals? We got to understand the medical, legal, and regulatory environment. Some of these algorithms clearly need regulatory approvals. And then the ethical issues around data sharing, privacy, and so on and so forth. So those are some of the pitfalls that are available, but society is sort of evolving towards the use of such algorithms in medical decision making. And so the way I see what will happen in the future is that with acute stroke itself, we'll use simple and pragmatic imaging. But this will inform clinical decision-making supported by AI. So remember, humans will always be there to use simple techniques supported by AI. Thank you.